welcome to this session with Sarah-Jane Marsh, who really kindly has come and joined us together, who for the next month or so is the Chief Exec of the Birmingham Children's and Women's Hospital. What we're talking about today is actually around decision quality and the role of analytics in that. Those of you that have been part of the Insight, been watching the Insight sessions for the last week or so, will know that we focus heavily on decision making, because we clocked this, that the integrated care systems to operate, anybody who's got to operate in a world where they've got multiple partners requires a method or methods around decision making. And so Sarah-Jane's one of the people who's joined us over this, is joining us and has joined us, who's going to talk about her own personal experience in the roles that she has played. Before I get on to the proper in-depth bit, we've got some housekeeping stuff that I think was up a minute ago on the slides. The housekeeping is things like, I'll try not to swear. Those that know me well know that that might be a bit difficult, but that, you know, stay on mute if you can. Oh, thank you, my memory's not great. Say hello in the chat box, use the function to raise any questions. We've got a great team supporting us, Rachel and Deb here today, so if you've got any technical problems, please do ask them and they'll help you out. We're recording these sessions so that they're put on the website, and you know, twitterers, whatever you are out there, please do hashtag Insight 2022, and there are our tags there as well. So at that point, I think that's all our housekeeping. At this point, I'm going to say welcome, Sarah-Jane, and congratulations on your CBE and your new role. Tell us a bit about that.
Oh, thank you, Karen. The CBE or the new, I could spend the whole hour talking about my trip to Buckingham Palace, but maybe that's not what people have joined for. Yeah, so I'm delighted to have been appointed as the National Director for Urgent and Emergency Care, and also taking on some Deputy Chief Operating Officer functions at NHS England. I'm starting in the new year. Some of it's a continuation of work that I've already been doing around discharge, but obviously a lot of it's new. And the big thing that's new is leaving Birmingham Women's and Children's after 15 years of service. So that's tough. Talking about big personal decisions, that's tough. Yeah, it's been the best job in the world. I think there comes a time when I don't know, 15 years feels like a bit of a turning point for anything really. And I just came to the point where I thought I probably made as big a difference as I could. And I want to try and challenge myself in a new and different way, and try and take a bit of the values elsewhere. So yeah, looking forward to it, but also I'm going to need IV fluids for the last week in December. Hooked up.
I was going to say, the tears are going to be flowing, surely, the relationships.
I'm quite the tears flow most days. So it's been quite a lot already. Yeah, so I'm just like, stop me now, put me in a cupboard, to get me out at the key moments. But yeah, but tough. But I know that the organisation will be absolutely fine. The values are there, and if you've got those, they'll guide everything through. So yeah,
absolutely.
But thank you.
No, absolutely. I mean, it's amazing. You have had a great career. You're a great role model for female leadership. I just wanted to say that. I'm a little bit fangirl, so I follow you on Twitter and all the rest of it. So people be aware. I might be a bit, you know. I can see Lise Edwards is here, who we both know very well.
Lisa's one of my best friends. Yeah, she's like fangirl. She does tell me I've got it all completely wrong.
Yeah. So yeah, and Lisa and I know each other through our liberating structures work. Okay. So yeah, absolutely. So yeah, a hugely successful career. You've seen the merger with the Birmingham Women's. You've created the largest specialist hospital in the country, and at the same time as all those national roles that you've talked about. I don't know how you find the time, but you've clearly got an amazing team for you to be able to do those things. So that's just, you know, again, great credit to you for creating that space. As I've said, bit of a fangirl, follow you on Twitter. And preparing for this, I spotted on your Twitter header the cartoon image of the signpost that says left to simple answer and wrong, and right too complex answer, but right. I'm guessing you're very purposeful for doing that, because I've got no idea how to do that. So well done. So technically well done on just doing that. But kind of tell us what that signifies for you. And I'm guessing your approach to decision making.
Yeah, thanks, Karen. So I only changed it recently. Actually, the one before was about talking about being kind, and it is. I'm not great at technology, so it is pretty easy to do. Yeah, but I spotted it actually on someone else's post and thought that encapsulates a lot of what I feel. The challenges that we collectively face in NHS leadership at the moment. Clearly, these are really challenging times right across all parts of the service. They present themselves in more obvious ways, don't they? You know, in ambulance and emergency departments and things. But the whole system is under a huge amount of pressure. And I think what people are often looking for everywhere, be that managers, clinical leaders, senior leadership people in NHS England, politicians, etc., they want things that are going to work and impact quickly. I guess you would call them the silver bullets. What will make a difference? What are the fixes for this? I think there's often an assumption of linear relationships between an action and an outcome, that in healthcare many of our processes are so complex that they don't really work like that. So it doesn't mean that if you do this particular thing, that thing will happen. They're related in some way, but I think the way I try to describe it is it's more like a chemical reaction than a linear relationship, and I can't always draw a chemical reaction on a slide. And yeah, the world isn't like that, and the way that people work, experience our services and the people who provide our services, not like that for them really. And I think that's what that slide is trying to signify, that actually we do need to break the problems down into the component parts. We do have to take on the difficult challenges. We do have to walk that path that sometimes is more challenging. So yeah, that's why I just stood out to me.
No, absolutely, and it really resonated with me, because and that path could take a long time to reach as well. You don't know what direction it's going to take you, and also it won't be done in 2 months, 3 months, 4 months. However target driven we can sometimes.
It is, yeah. There's many people on this call may know of Jill Phillips, who does the Who's Shoes. She's really big on social media, and I've done a lot of work with her in the past on maternity. And she's got this thing around evaluation where she gets out a paper chain. It's like the question is this working or not? And she gets out the paper chain and goes, I don't know, is it? You know, because what we're doing is making 20 or 30 connections, and they're transformative, but we can't necessarily always associate the story that we told with the impact that means that someone will go and do something differently or treat somebody differently tomorrow. So yeah.
Yeah, absolutely. So thank you for that. That's great. And I suppose at this stage we should probably qualify the type of decisions we're going to talk about today. Yeah, the reasoning for being here, for inviting you, because those important decisions about what family holiday we're going on are important, but we are talking about kind of decisions that are often. A colleague of mine, Fraser, does a lot of decision quality training, and he talks about high consequence, infrequent, hard to reverse, cause and effect are uncertain, the daisy chain you described, and will create disagreement probably between reasonable people. In your role now and in the one that you're going forward into, does that resonate with you in your experience?
Yeah, I when I was invited to do this session, I thought, good grief, what do I actually know about this topic? And started to think through, and yeah, I think if I think about some of the big decisions that I've had to lead through, I'm not entirely sure I've made any of them on my own, if so to speak, but the big decisions that you have to lead through, I do think you've got all these different factors. You know, you've got what's the data, what's the impact, what's the evidence, have other people done this before, what happened to them, how will it feel, will it bring benefits, how will it impact patients, how will it impact people who work in the organisations, is it something that communities want and would benefit from, is there an opportunity cost of doing this versus something else that we might do. I think all of those things really resonate when you're thinking about these, sort of bigger, sort of complex decisions. I think in the NHS as well, being an NHS leader / manager, you've got to do, it's that close working relationship between management and clinical leaders as well. that's really critical. We've got to think about, you know, how those two things interact. And I think that's true in all the different roles and levels that I've worked at. You know, I don't think there's a massive difference in the way you face into things. I just think the more steps back you are from the implementation of the decisions that you make, sometimes the more complex the decision making is about, you know, exactly what needs to happen. Is it really going to work as we intend? You know, if I'm at BWC at the moment and make a decision about something, I'm only 1 or 2 steps away from the implementation. But as I go up into some of those national roles that I do, and the one I'll be moving into, I'm really conscious that intent and delivery on the ground may be a lot more disconnected from each other. So you have to think about decisions, I think, a little bit differently then.
And just, I mean, going back, we'll talk about your coming new role in a mo. But just to focus on the BWC, did you have a special approach that you employed around decision making? Was there a process that you followed, or an example that you could give us?
I think so. I think it depends kind of what the decision is around. So I think sometimes, quite a lot of decision making in the NHS is about prioritisation. Although it doesn't always present itself like that, because at any one time, if you're going to do 2 or 3 big transformational changes or developments or whatever, that's probably all that people have got the bandwidth to do. And often the decision making is about which path we go down. Do we go with this option? And sometimes we're not quite as clear as we might be. I think that's what we're doing. Yeah. Things may present themselves in isolation as a decision, which you really need the broader context of to be able to make. But that's a part of it, really. I've lost my thread. Sorry, what was the question you asked me? Have I got examples of that?
Yeah, have you got an example you might share with us of a big?
Of the models, yeah. So I think we've had some quite sophisticated approaches around prioritisation. We're really lucky in BWC that we've got a consultant in public health, Chris Chiswell, that's actually done a lot of work around decision making methodologies and has been able to use approaches that I always say this is the standout example, where you get clinicians from not their own team agreeing that prioritising somebody else's service development or thing objectively is a better thing to do based on a set of criteria. So we have got methodologies that we've used. I think the main sort of change model that I've got in my head when I approach anything is to try and listen to as many people up front on whatever the issue might be, and try and keep the funnel really quite wide and engage with as many leaders, people who work in the organisation, teams, users of services, stakeholders, volunteers, whatever that might be. Keep the funnel quite broad, and then start to narrow it down as you hear what people are thinking and feeling about particular topics, and then try to bring it into governance structures when you're closer to the end, rather than maybe writing business cases. It might not even be the right solution that we're even debating whether we go ahead and implement in the first place, because we've not done that sort of search in the first place to say, is this the right solution? A little bit back to the diagram, is this the right solution to the problem that we faced? So I think that's sort of being quite consultative and working down a funnel. I think
listening before you make kind of, like, even to the point before you even got to really what's the proper question we're asking here. You've spent time listening to people, because I'm guessing you've got an area that you're thinking we need to change something here, but we don't quite know what it is yet.
Yeah, it might be like anything really. What are the priorities? Where would we do estates development? Is digital more important than this? Or how's what like recently what our approaches might be to supporting people's well-being at work, with cost of living being even more important, rather than just saying, well, we've got a decision to make about whether we do this or this. It's actually, what are the real experiences that people inside the organisation are having, service users, families, and therefore what sort of things would help and support people, and keep that quite broad, rather than saying, do we give all our meals cut price? Just coming up with a solution that might not be the right one. I think having a path through the decision is important as well. So again, it depends what it is, but sort of significant things that require big business case and things, I think it's having an endpoint when you want to make a decision by, and working backwards through what those checkpoints are, because I think sometimes we can let things drift out and say, well, I need a bit more information, I need to ask that person, let's defer it to another meeting, then that, you know, and things kind of drift out. So saying, actually, we need to have made a decision by this date, so what conversations do we need to have, you know, in the months, weeks that are leading up to this, to make sure that we can make a decision when we need to.
And I can imagine having a public health specialist, they're always great anyway. Everybody needs a public health specialist alongside them. Yeah. But having one alongside you with that, that's to assist is great. And I can imagine that's hugely helpful to look for somebody with that expertise. What about the broader analytical expertise? How do you draw on that from a decision-making process?
So yeah, I mean, so I think one of the things that we're better at in the NHS is having analytics often around the way our own organisation is performing. A lot of the metrics and things that we have at the moment are more organisational. They tend to focus on the things that we know, particularly in a hospital, because they're the patients that present to us, they're the lengths of stay they have, they're the outpatient appointments they have, they're, you know, whatever the pathways that they follow. With some of the data around the population, I know it's starting to come through, but is a little bit weaker, and often the people and the services that we should be most concerned about is the ones that we don't know anything about and we haven't seen, because they're not the people who've made it to our services in the first place. And then increasingly now with ICBs, it's what does that system kind of analytics look like? I think in general we have some issues with analytically led, data-driven approaches sometimes in the NHS. There's a real balance, I think, between what the data tells us and what people are feeling and experiencing. Some of that's just to do with how people are. I think some of that's to do with data quality. It's how you marry the two things together and which way round it comes, whether the analytics gives you the answer or whether the analytics is demonstrating the impact of the outcome that you're thinking about anyway. But yeah, I think we do need to be a bit more geeky, if that's the right word.
We're good with geeky. We're good with geeky. I've got my pointy hat. I've got my Christmas tree. I've got my pointy hat. And from a strategy unique perspective, we bring the qualitative, so the voices alongside the data, and actually look at them in a joint way. And all my evaluation friends will kick me for not using the proper words here. But by bringing those two things together, they influence each other and how they tell you the full story. The feelings and the experience alongside with what the data is, and there's great value in that.
I think what I'd add, Kat, when I went on my secondment to the DHSC in the pandemic, the test and trace director of testing role, the majority of the colleagues that I work with in the executive team were from the private sector, not private healthcare. They were from banking, technology, pharmaceutical, you know, and so on. They were all, from the very first minute, kept talking about citizen insight and sort of setting up 3-4 times daily meetings to look at how citizens were interacting with the services that we were providing, almost in that real time. And if we do this, if we change that access route or that bit on our portal, what does that do to people's behaviour? And I was used to looking at the same sort of data in the NHS, maybe monthly, quarterly, and just not that sort of really regular. Now, I'm not. It would be much more complicated to do that in the settings compared to that, but it did make me think. And the other thing that really made me think was that the culture then was trying to change the service to the way people were behaving, whereas I think often we try to change people's behaviour to the services that we've got.
How often do you hear if only patients would act in a certain way, and we know that that's not the way round it should be?
I think there are people that are good. It's probably a bit of a generalisation, but this was quite on the sort of people aren't going to do that, are they? We can see that from the way people have responded today. They won't respond to that, so we now need to think about doing this differently. Otherwise, tomorrow that will happen. Like I say, it was all very condensed, but you can see that if we were doing that, with some of our healthcare data sets, and that's how disciplined we were about looking at the way that people were behaving and insights. And I think that becomes really important when you think about the situation we're in now, where we are having to think about taking different risks across the system. And it's the way that clinicians are responding to that risk taking as well. Do we really understand all of that? You know, that is, I think there's a lot more to do there.
Absolutely, and you can see that really coming into something where an ICS has created a change, is carrying out transformation. And how do you get that that patient voice, or user voice, or citizen's voice, if we're working in a social and healthcare setting through?
Yeah.
We've still got a lot to learn. We've still got a lot to learn. Absolutely. Yeah. And so, I mean, you've helpfully brought me on to kind of my next question, and I was thinking about what's the difference. So when you went and did test and trace versus chief exec of BWC and decision making,
that's a whole seminar series.
Okay, well, maybe just around decision making, and kind of, because you had, you've got your board at BWC, whereas there you must have had, the stakeholders must have been immense. Just a little bit of a feeling of around some of the challenges.
Yeah, absolutely. I think some of it was about speed, and some of that was to do with being in a global pandemic, to be honest. So the things couldn't wait, and we couldn't always wait for the extra information, the extra data, and so on. I think it was like a startup. So it wasn't an established governance structure in the same way that an NHS organisation or an NHS system might be. As one of my quick learnings, actually, because I think all of us in leadership sometimes would go, governance processes, I've got to go around this loop or that route. I think after about 3 or 4 weeks, I remember saying to someone, God, governance is really quite useful. It does help us to really have a framework around decision making and things. So I think that sort of little bit of a lack of structure, just because of the way the organisation was created, and then that the sort of speed of decision making, but also the inputs. And I think that's one of the differences between working at a local level and working at a national level. I think at a local level, people say there's nobody else, there's not another group of people somewhere else in a room thinking about this problem. It is us. I think in national roles, there are other people in other rooms thinking about the problem, and things can emerge, and you have to be a lot more fluid, I think, sometimes in the way that you sort of receive feedback and manage processes through, because things will change, and there's a lot of, the hierarchies are not always completely clear either when you've got sort of different arm's length bodies and different parts of government and so on. You have to be just a little bit more fluid sometimes in terms of the way the decisions and things work.
Absolutely. And I'm just coming on to you start your new job. Fantastic. Let's assume for a moment it's your best friend who landed this job of a lifetime. Okay, remove it from you for a minute, just kind of assume that it's your best friend. Assume it's Lise Edwards. What advice are you going to give Lise? And what would you say to watch out for? And what should she build on?
Yeah, so I'll bring it back to decision making, but there's a few things just to start. I think the first thing is keep your feet on the ground. Like you're still the same person, and it can be quite. I've already done a few sort of initial things where, because of, if people know the way I work in the roles I'm in now, I'll say stuff and then go, that's not right, Sarah-Jane, or that's rubbish, so let's start again. I have to keep saying, just because I've said it doesn't mean it's right. So I think there's an element of that, just kind of really making sure that it's just a role like any other. I've got a phrase that I live by, which is no hierarchy, just people. When it comes to decision making, there's no hierarchy, and good ideas, they can come from literally anywhere. So they don't come from you because you've got a fancy national title. So I think that keeping that in your mind is really important. The second thing is the things that work still work. I learned this in 2020 in quite a big way. I thought maybe there were other ways around leadership. There were some shortcuts basically, but there aren't. So I still think a clear purpose, so people understand why they come to work every day, a set of values that dictate the way people behave, and a climate in which people can be successful and can feel supported and challenged simultaneously. Working as a team gets you the best results, and I think that is true of anything that I've led in. That's go back to the shortcuts. Tried some of those shortcuts in the pandemic, and they don't work. 'Cause if people don't have that set of understanding, then you won't get the best out of people. So they're the same. I've mentioned the thing about there's a bit more parallel lanes, I think, in national roles, just really being aware that it's not. I think if you work in frontline services, the structures above probably look like they're a little clearer and more simple to work in and operate than they are in reality. It's hugely complex. So I think you have to be really aware of the way you've got all those kind of interfaces and things when you work at national level, making sure that people feel like they can challenge. But I think the main thing is, I come back to what I said a little bit earlier on, when you're thinking about decisions, you've got to think about the way that they are going to be received and impact into frontline services, and whether or not they are useful. So the one thing I've always said in the national roles I've had so far is I want somebody to pick it up, a director of midwifery, a children's lead, or now it would be like a chief operating officer, I guess, in this new role, and go, oh, this is useful. This is going to help me to do my job. And there's only so many things that you can do in a national role that's true of. There's only so many things that you can enable and uniquely bring. So it's trying to identify those things and make decisions that focus on the things that only national bodies can do, to create a framework for people on the front line to then be able to interpret and do the best they can with the resources that are available. You can't micromanage. You can try, but it doesn't work. There just isn't it just doesn't work like that. Not in an organisation. Well, it's not an organisation, is it? The NHS, it's a series of systems. So you just can't work it like that. So that would be my advice.
That's great. And that really. So your first one, I think, was about humility. Just have humility. You don't know all the answers, other people will have those. So no shortcuts. I like that. Purpose, values, environment, making sure they're all right. Understand the parallel lines and the interfaces, and then is this going to be helpful? So find the thing that's going to be helpful to somebody who's going to be there, and you can't micromanage them. I think that's great words of advice. Thank you. Is there anything else around decision making you'd like to share before we open it to the audience and we ask if they've got any questions for us?
There's a couple of things, and I made some notes that I've not mentioned. I think the first one is about the emotion in decision making, and the longer that you've been associated with something, the more that comes in, I think. And like one of the examples around big decisions is about whether to merge. You mentioned it in the opening, like the decisions about whether to merge organisations and things. You can, I suppose it depends what sort of how you interact with the world, but I feel quite a lot of things. So I think you can't disconnect sometimes the emotion. I can feel it rising in me sometimes. I say, I'm going, that's the emotion in me talking, so we'll now put it in the drawer. But I think it is there. And then the second one is probably a little bit more controversial, but I do believe it's true, and I feel I've got the self-awareness to say, I think the more senior you become, or the more time you've become a chief executive, I do think you have to manage your own ego in there, because you recognise scenarios, you think I've been here before, and you kind of think you know best in a way. You can't stop yourself, and there is a little bit of a danger. It dictates decision making more, I think, than it would in earlier years. Now, I've been really lucky having Professor Sir Bruce Keogh as my chairman. He said to me a couple of times, let's just break down what's driving this, and that's been really helpful. But I do, and I'm saying it, I'm guessing a lot of people who use it more wouldn't even say it, if you know what I mean. But I do think ego does make its way into quite a lot of decision making everywhere, not just in the NHS, everywhere.
Because you can't help it, can you? It doesn't matter if it's something you've already done before. You think, oh, I know what the answer is. Just if we just go and do this thing, it'll sort it. But that was previous, wasn't it? It's not now. And it's not in these circumstances. Yeah, and sometimes I hear myself saying, oh, we tried that, and I'm like, no, I'm that person who said we've tried that before. Don't be that person. So yeah, but I just think they're important to call out, because they're real. These are people essentially, aren't they, with experiences coming together to make decisions on things. So yeah. Absolutely, absolutely. And even as the chief exec, you do get distanced from things, don't you? You know, especially So letting those other voices come through is incredibly important. Thank you for that. I'm just looking at the question. So Lisa's had to go. She says, she'll catch up with you soon. From Rosanna Brown, we've got brilliant sessions, so refreshing, frank and informal. NHS England are getting a fabulous person. I couldn't agree more, Rosanna. Any of my colleagues on, are there any questions that have come up? Oh, Abby's also, so Abby's one of my, she says, I'm your qualitative friend, when I was talking about it earlier on and giving all the wrong names to that kind of stuff. But both you and Bola, because we interviewed Bola Edouard, oh gosh, sorry, my apologies, Bola, stated that the first and most important aspect to start the decision-making process was to listen. So you and Bola are absolutely aligned in that. So lots of bits about decision quality training that we do here as part of the Midlands Decision Support Network. Has anybody else got any questions? Please do feel free to come on if you're brave enough. Just put your hand up and come on. Oh, here we are. We've got one from Matt. So Matt from the HSJ here. Be careful, be careful. Thanks for the talk. Can I ask Sarah-Jane about her work on the National Discharge Taskforce? What models on this will be getting the most attention going forwards? Is that a fair question? I'll let you decide whether that's a fair question, Sarah-Jane.
I think that's an example, if I've understood it right, of some of the things that we were talking about at the beginning. So setting up a discharge task force and trying to get fast impact on areas where we've got evidence that those things will make a difference, versus what are the medium long-term models that would be more transformative in the way that patients and citizens experience the post-hospital or post-community service period, hopefully in their own home. So yeah, I think we are doing quite a lot of work on that at the moment. It's we've had a lot of interest from people who want to do things differently. I think discharge is one of those things, again, I feel quite emotionally passionate about. It often gets presented as a people in hospital beds and that's stopping flow and that's stopping ambulances and all the rest of it. But a lot of the stories and the experiences that we've heard through on the task force are really about people who really, really don't need to be in hospital. They need to be at home. They need to be rehabilitating, they need to be re-abled, they need to be given a chance to enjoy the rest of their life. And so, you know, and that's what's driving people, I think, a lot to come forward with these different models and say, is there a different way? And what I would say, Matt, is that a lot of that is about how all the services join together. So what's happening, particularly between NHS community services and social care providers, you know, can we look at some different ways of delivering those services so that everybody gets the care that they need in a timely way? So there'll definitely be more on it to come. But yeah, it's a brilliant example of, like, if there was a fast solution to this, we would have found it. You know, we would have, if there was a simple solution, we would have done it. But it's hugely complex, and just working through with different teams on the ground, really, what the best models might be.
Again, not linear, complex. Requires lots of listening, all the things that you described.
Yeah, not linear is lovely here. It's a perfect example of people looking for, particularly with the criteria to reside data, looking for a relationship between that and ambulance handovers, and it's not quite there. I think what we're all striving for is to look at the occupancy levels that we've got in all of our services, because we know if occupancy exceeds a certain level, everything becomes more tricky. So how do we try and get the right people in the right services and keep occupancy at a level where we can support the flow of patients into the right services? So yeah, and this is one of the things I felt like in thinking about sort of moving to NHS England, I really feel passionate about this agenda.
You seem really fired up. Obviously you are, it's a new job. Who wouldn't be?
No, I am fired up. I lost my dad in November of last year, and he wasn't a delayed discharge by any means, but he did have one of those kind of quite typical end of life pathways, and I did end up at needing to phone an ambulance that I probably didn't need to have phoned if there was other services and so on. And so that was one of my drive. I think a few people thought, well, why would a women's and children's hospital chief executive accept a job chairing a discharge task force? I did say there's lots of people who know more about this than me, but I just felt like I believe in fate, completely believe in fate. And I thought, I've just had that experience and it's made me think there's a job to do here, and perhaps that's a legacy I could leave. So that, and anybody that's had any loved one or any relative go through a process like that will feel the same. I think how we could make this better. It's not because being in hospital is the gold standard and we're trying to get people out into something so the next patient can get in. It's because people want to be at home with the right support, not in hospital. They're ready to
what
move.
a privilege to be able to take that really sad occurrence. I'm very sorry to hear about your father's death, and do something incredibly important with it as well.
Yeah.
And have that as a driver. So I have got some more questions.
Okay.
If you're okay.
Yeah,
oh gosh, what have I got here? Oh, it started. Oh, see, so my colleague Abby, humility, emotion, and ego. These are not things that all leaders talk about. Do you think? So talk about. Is it? Let's talk about more about your female leadership. Okay. How do you tackle being a female decision maker and your clearly different approach to many people in your position?
I think it's become easier over time. I found it quite difficult. Well, we all have imposter syndrome. It just accelerates at different points in time, doesn't it? I did a talk at the Academy of Medical Sciences and mine accelerated into like 6th gear a couple of weeks ago, and I was sat between those two geniuses going, so, but in that first 3 years or so, I think I was striving to be what I saw other people being as a chief executive. And I think that's probably happens, with quite a lot of people. I then went on maternity leave. I was a chief exec quite young. I had my first baby after I'd been a chief exec for 3 years. And I don't know if that changed me per se, but I took a step back. And when I came back, I thought, maybe you do know how to be a chief exec. Maybe you've demonstrated in that time. And I think that started to build my confidence in terms of sort of being able to show more of my authentic self. I think then being the chief executive of a women's and children's hospital, if you can't talk about some of the issues that we know affect a predominantly with female workforce, then who can't really? You mentioned to me earlier around menopause, Karen, that's one example. Loss of any description. We all carry things with us that we need to share with people. Obviously, lots of people have got children, that affects their work patterns. It doesn't at all, to me, demonstrate anybody's commitments or anything. I have a lot of consultants come to see me pre-interview, go, I'm only going to be able to do, 0.8 or whatever I feel. And I'm like, no. I have seen so many people come and do 0.8 jobs that are so much more efficient and effective, because when you've got to get back and you've got to do it, you're like on it completely on you, to get to the point you need to by the time you need to leave. So I think it sort of grows and comes over time. And one of the reasons that I carry on to talking about things now, because I think I've paved my own way and kind of earned my own right to be there. But I hope in doing that I can encourage other people to want to think that anybody can do anything they set their mind to, really, with the right sort of skills, experiences and so on, but also that people will think that's okay. That's my hope.
And I mentioned your role model as a female leader role model right at the very beginning of your introduction, and I think you've just concreted that for me in just what you've just said. So thank you very much. That others can do it and can be themselves, and all that authentic self.
And I think that's what people relate to as well. Like it's you read the same about politicians and things, don't you? People want to know you. They want to know you. They want to know that you care about them. And they want to know that you've got the best interests of them, the organisation, at heart. And then lots of people will follow. They don't really want to get involved in big decisions, strategy, whatever. They just want to know that you care. When you show up, you care about them. And you can't do that if you're not authentic to yourself, I don't think.
Absolutely.
So it's critical to get in the trust of people.
Can I get an early one on this one? Are you going into the celebrity jungle next winter? Are you know?
Oh, to be like Strictly would be my dream, but I certainly don't meet any criteria for Strictly.
Okay,
let's see. Don't meet any criteria for Strictly.
All right, we'll go for Strictly. You can be your authentic self on Strictly. That would be absolutely fantastic, wouldn't it? I still got some more time for some more questions.
Yeah, of course, yeah.
So, Simon, it's great to hear, as I said, it's great to hear you talking about your decision-making practice so candidly. And how might we support leaders across health and care to adopt a more reflective approach to decision-making? And perhaps focus more time and energy in developing their practice, becoming more evidence-informed in their approach. Bit of a long question.
Yeah, I mean, I don't think enough time is spent on this element of leadership development. I mean, I really think we've done some brilliant leadership development programs across the NHS over the last sort of 5-10 years or so, but I do think we need to bring back some of the more skills-based training and development that we used to do. And I think this is an area, particularly as we move more into system working, where we need to equip people with the tools, the techniques, and also the practice, as you said, the reflective practice around it, because increasingly there's decisions that may not be the best for your organisation or the population that your organisation serves, but they are better for the system or the population group as a whole, and that makes decision making even more complex. When you've got to be balancing off those two things. You'd want them to be aligned, and often they are, but sometimes they're not. So I do think we need to carve out some time to be able to do that and bring back some of those things. I mean, I feel really strongly about bringing back some of the stuff around sort of process improvement and things as well, just so people have got as we said before, what problem are we trying to solve? Have we defined it in the correct way? Therefore, how do we get into that key decision making? Because the best decision making really is when people on the ground say, this doesn't work, we need to change it to that, we'll have a go this afternoon, we'll evaluate it in the morning, and people like me never get remotely involved. That's the sort of decision making you really want to be happening, isn't it? You know, all this you said, we did, it's like a parent child. We need an environment where we say something and then we do something because the culture that we work in supports us to be the we that makes the change, and that's the goal.
Yeah, it's back to your 4 things, creating an environment, no shortcuts. You've got to create the environment for people to be able to feel that they can make those decisions. We've got loads of questions now, Sarah-Jane, so we're not going to have enough time for everybody. So, so I'm going to go down to Rosanna. Thank you, Rosanna, for your question. How do you encourage long-term system change against short-term pressing priorities? Against the backdrop of shrinking resource? Everybody's dealing with that, aren't we?
Yeah, I think part of it's just trying to carve out a bit of time to be able to think through where it is you're trying to go, because that still feels important. But the thing that I've tried to do in all the different tiers that I work in is the short-term moves that we do, the short-term, it must walk us towards the long-term goal, because there's no point that we're going to stop doing today so we can focus on tomorrow. So that's true if we think about emergency care or mental health crisis or rehabilitation in the community. What steps can we take this winter that take us towards what we would want to be as our longer term goal, particularly if we think about like the number one thing I think for ICBs really is around tackling inequality and making sure that everybody gets this. Well, not everybody gets access to the same services. Lots of people need more accesses to services to get the same outcome. But if the inequality strategy was the strategy, I think we'd be a lot better at delivering. So that's an example, is how do we look now at, you know, the people who are the highest intensity users of our services, and how do we think about delivering their care differently? And that would help us this winter, and that will help us going into next year, and that helps us to deliver the long term aim. So we've got to try and think of this, the two things connected, I think.
Lovely. So that's kind of giving people space, but also kind of, I'm seeing you describe, or I'm hearing you describe it as a journey. The thing that we do now is not necessarily our end point. We're taking steps towards it, because there isn't the time that is constricted, etc., etc. So I think that's,
and I don't see it being, I don't see a glory day, you know, next March when we can stop and be strategic. Yeah, like I don't see that day. So we have to keep going. Yeah.
Lovely, lovely. And just to carry on, Rosanna had gone on, if we do you think if we invested in asset-based community development and work around the wider determinants of health, we might take some of that burden off the NHS, and health life expectancy would be increased?
I do completely. I mean, obviously I've worked a lot with children and young people, and the example that they always say, and it always resonates, I always use it as the best example, is around young people's mental health. They often, you know, when we do the groups, or when they sit on boards, and all, you know, they'll always say, just because somebody's got a mental health problem, don't start trying to refer them to something. We're just saying that you know, give us the tools and technique, we can help. We're the people who spot first that someone's not eating at lunchtime. Help us to understand what questions we might ask or whatever. Don't make it an identification so we can make a referral. What is that? And young people are brilliant at working like that. I sometimes think just step out the way and let them get on with it. But they are the biggest asset that we've got, I think. And often when we think about, I don't know, like vaccination programs or whatever, it's like give young people the right information in schools, and they'll be the one who go home and tell, you know, talk to parents about what's needed. So I absolutely think, yeah, that people are the asset, and we need to think more about the citizen engagement, the citizen offer. You know, back to what I was saying about test and trace, people are always, well, what do citizens want from our services? And that's, people want to be empowered with the information to make their own decisions and help and support each other, often not be that sort of parent child, I'm passing this problem over to you now for you to solve it, and I'll tell you when I'm ready to discharge you from my service or step you down into, you know, general practice or whatever.
Lovely, great answer, thank you for that. Amanda's asked, or is it a statement? I'm just going to read it out loud and we'll see where we go. Would be good for more training to be available across health and social care professionals. So, you know, so leadership and decision-making skills, regardless of all the organisation. What's your reflections on that?
I honestly, one of the best things about the last 12 months has been my friends that I've made in social care provision. I very naively, I feel quite embarrassed to say, thought about social care as local authorities. Actually, when we get close to social care providers, the people that are on the front line every day delivering the services, they're saying, well, I'm not sure we're doing that right. I'm not sure we've organised that in the best way. And the power in the ability of bringing health and social care providers, teams together, you know, from the individual examples where people have told me, you know, they've been looking after someone at home maybe for 10 years, they get admitted to hospital, and then 10, 14 days later, they're unrecognisable, and they're saying, just ring us, just help us. We know how X likes, you know, all these things. Let's just work together. We'll take them back when they're ready. That doesn't happen unless you've got those relationships in the service delivery, and then we've got health and social care providers sort of together. So that is one of my missions in this, that we need to get social care as a provider, like really embedded in everything that we're doing in health and care. Yeah, so and then you know, all practitioner levels, so completely agree.
And I can see your face light up then when you answered that question.
Yeah, I'm just thinking about
can't wait.
No, I know the task force, there's a lady on there called Nadra, and she's absolutely fantastic. I always say to her, you know, we've got this policy, we go, is that right, Nadra, has that actually happened? And she'll go, oh, it's happened somewhere, Sarah-Jane, you know. And that's when you really know, and it's so important that you've got that, you know, when you're in this, you need to know whether things are really landing and making a difference on the ground. So yeah, I think there's a massive opportunity for us to build those relationships and get much better outcomes.
I look forward to that happening, and I've got absolutely no doubt there'll be people on this call who are just kind of rubbing their hands with glee and getting excited about that. So final question then, because we're coming close to the end. And it's from Peter. Peter's asked, well, first of all, he says, thank you for joining us today. And you described the challenge of making decisions where some parties need to sub-optimise for themselves in order to optimise for the whole system.
Yeah.
What ingredients do you suggest will be needed to make this kind of system leadership possible?
I think it starts off with the trust and respect between the leaders. Now, this again is like, you know, where you've got people have been successful for for working in a particular way, and now success looks like something different. So I think that trust and respect needs to be there so that the intent is recognised, because sometimes things become I don't know, they can become tricky because people aren't clear on all of our intent, and often when you have discussions about why people are there and what their values are and what they're trying to deliver, they're very, very aligned. So I do think you need those relationships with that peer group of people sort of making the decisions. Then I do think there needs to be a clear route through that of doing that. I think the more people involved, the more stakeholders you've got, the more temptation there is to go away and search for extra information or paradigms, or we'll have to take that to our own board as well, or have to get our chair involved in that, you know. So let's be really upfront at the beginning about how we're going to make this decision, and, you know, when the end point is. We've done some great leadership development as a Birmingham and Solihull integrated care system/board with a team coach. And she's given us a model which is actually great, which is about, it's okay to disagree as long as we understood where we disagreed, but sometimes things are just left. So sometimes it's like, I can live with this bit, but I've got an issue here or there, but that's not called out, and then people walk off and they don't know whether they decided it or they didn't decide. And just actually having that time, so let's just check in on where we all are then. You do disagree, but you can align with the decision, great. You know, and work through it like that. And actually, when you get to the pure people who really cannot agree and cannot align and cannot, it's much fewer and far between. So I do think, again, it's back to needing some models that we can all kind of draw on, and then being able to call each other out and go, hang on a minute, I don't think that's how we agreed we were going to work, you know, rather than don't operating models, frameworks, guys, they're all, we need them, but the operating model is the conversation that we have. The operating model is the way we speak to each other on the phone. That's the operating model. Nobody gets out a piece of paper and says, what's the operating model? So we can write it down, but then we have to be it in the way that we talk and are together.
Yeah. That sounds like a great coach, because I can imagine that would be a method you could employ throughout your organisation, because decisions are made at many levels. And how often work that I'm doing, where often I'll talk to people and they'll go, oh gosh, but it'll go to that board and it'll never get decided. Because that's just what happens. We get stuck sometimes.
The other great one she's given us is drama triangles, and all you have to do is go, oh, I think we might be in a drama triangle, and then all of a sudden everybody steps out of it. Because they can see they're in it. But if you can't, you end up going, oh, X is a bit scratchy, or Y is a bit. But if you can just go, I think we're in a drama triangle, so let's just take a leap out, because it's not helpful. All those things are really massively helpful. Yeah,
absolutely. Especially, I'm a natural rescuer, so kind of like I'm always there in that drama triangle trying to rescue the situation. So I think that's another great tip. Thank you very much. I think I'm out of time. We've got literally 5 minutes. So I'm well, first of all, just the most massive thank you, Sarah-Jane.
It's a pleasure. I've really enjoyed it.
Really enjoyed this. I hope the audience has enjoyed it as well. It's been really fun, really informal. You've been so open, and it just leaves me to wish you all the best. There'll be a number of us who can't wait to see your career progress, as no doubt it will do, and do some great work going forwards in the future. So thank you very much. If people want to give a little round of applause, I think we're getting lots of little thank yous. Yeah, love the session, great session. Really lots and lots of stuff for that. Yeah, so such power in humility, I reckon, says Helen King. Thank you for that. And my last job is, somebody's going to put a slide up, because today's session, this session was our penultimate session on our penultimate day of Insight 2022. So the final session's tomorrow. That's got some, I'm going to guess that's the 14. It's a 2 o'clock. I'm going to guess that's a 2 o'clock till 3 o'clock tomorrow. Interview with Sir David Dalton. How do you get the desired results from your decision making? So taking the conversation I've just had with Sarah-Jane, that we've all had, and moving on. That's that step forwards. So thank you very much, everybody, and have a lovely rest of your day.